go, Phoebe, you're not introducing me?
Oh, all right. Thank you so much. Thanks, Candace. Thanks to Tannery too. You know, typical Sundays. I don't know if people get up early in the morning, watch all the talk shows, roundtables, all that, and come away totally kind of despaired about the confusion and craziness. However, Tannery has put on Tannery Talks to make some sensibility out of all of this. We had Bill McGibbon, as you all know, internationally renowned environmentalist, renewable energy. We had Glenn Pearsall, an author, major donor, contributor, financier, etc. So, you know, part of that. And now we have Dr. Rugge. Yay! So the Tannery Talks is really a major feature of Tannery, and so we want to thank them as well. So today, Don Preminger is up in the tech booth. He happens to be the treasurer and board member and so many different things, so thanks, Don, for doing this, making us sound good. Now, this is being videoed today, and so when we get into the Q&A, we have some handheld mics, which will get out to the audience, and then once the video is done, it will be posted on the Tannery YouTube station or posting, so you'll be able to get to see this. We'll take our time making sure that we get questions from the audience, because that's, you know, obviously part of the video. Full disclosure, which is always interesting. John and I have known each other since 1978, close to 50 years, and during that period of time, our journeys have been amazing, wonderful, and we won't talk about all of that. That would be really boring, but he and I talk quite often. And I promised him I would not share the bantering that we usually have at dinner. That too is probably boring, but we get into really some interesting, important things, you know, all the way from existential kind of efforts about how do we improve healthcare, how do we improve quality care. And so that's been good. But in those close to 50 years, John not only established and created Hudson Headwaters, which he did, from a little office in Chestertown, and then was the CEO, president and CEO for over 40 years, as well as a practitioner, a primary care practitioner. So he was a triple threat to the community. And now it's continued on with Dr. Slingellands, who is actually offering really interesting and expanded programs, innovative approaches, and really is a stabilizing leader in this period of time of great craziness. So if all of you have handouts? Yeah, good. Because we'll use that as well. So John and I will just start some Q&A in the beginning. We'll take a few of those minutes, and then so as you're thinking either looking at the handout or thinking what John has to say, please jump in, because that really what makes this rich in terms of understanding what's going on in healthcare. As you look at it, doesn't take anybody to kind of think that we're in a crazy period of time in terms of healthcare at all levels, all parts. Major changes going on. And for Medicaid, that becomes absolutely critically important.
Just make a little comment.
You can do anything you want. It's your show.
He's just observed that we've known each other so long. I got to know him before I was 60.
Here we go. I told you we would not display our pantry. I was only 20. No lies tonight. Anyway, as I say, healthcare is going on. It's really crazy. And so tonight we're really going to help us all understand. Medicaid frequently was not really even thought about. Most people didn't even know what was going on. Oh yeah, Medicaid, I've heard about that, okay? 1 out of 7 million people in the state of New York, 1 out of 3 individuals are on Medicaid. 1 out of 4 families, 1 out of 5 children. It is the major insurance program for the poor and disabled and for long-term care. Almost 80 million people across the country. So you're talking about a major program and really trying to understand what that means, either the potential cuts coming down from the federal government, what the state's doing. So part of the coalition effort really is to try to help us understand all of that. The coalition is really quite remarkable. It started about a year ago, John, right?
February.
Yeah. So February to now, John and a handful of individuals, many in the audience here tonight, so thank you, And from that, during that period of time, that coalition is now up to over 250 individuals, produce a major white paper, which the summary of the handout today is available, as well as public appearances all over the place. In fact, John was going to leave here after our session and head to Saranac for another presentation because of snow and other kinds of things. They're moving it to a Zoom. So this is this constant effort to try to educate and inform our community, local leaders about how important Medicaid is, because it just ripples through our communities in so many different ways, and we're going to start right in on it. So John, the coalition is a really important piece. I've been involved in healthcare policy for a long time. Something this is really quite, really magnificent in many ways, where people have come out and said, look, we understand that, we want to be part of that. That's really fantastic. So what is your major message to everybody today?
What we're trying to do, number one, is share an understanding what Medicaid is. When I first was practicing, I thought I knew about Medicaid. It was past 60 years ago. Same time, anyway. And without giving the assured insurance to people under the poverty line. Well, what I didn't come to appreciate until we started this coalition is how complicated and what a tangle Medicaid has become, a good tangle. For one, the poverty line is no longer the platform. It is 138% of the platform for a family of 4. That means $32,000 per year. In addition, over time came the CHIP program, Child Insurance Program, the Webb program, Women, Infants, and Children, and then, not least, Obamacare, the ACA, Affordable Care, which has a number of components that allowed for enrollment in Medicaid at the level of 250% of poverty, and also extended that to something called the premium tax credit, which I've never heard of until starting all this. And that is people up to 400% of poverty are qualified to, on a sliding scale, have a tax deduction by signing up for a qualified health plan. So we now, as Arthur has mentioned, have 7.7 million New Yorkers, and for this area, the North Country, I should get to that in a minute, we have 608,000 people, population. We're defining the North Country now as between the Vermont border and Lake Ontario, 10 counties. Of those 608,000, 170,000 are enrolled in Medicaid and have the benefits. And we want to take care of them as best we can. And it's not only doctors who are going to do that. It's all of us together finding ways to help.
So John, healthcare is really political. It is highly politicized, quite volatile, as we've seen over the last 3 weeks with the shutdown, where they were able to stop government attempting to ensure the continuity and continuation of certain health policies. But you've made such a point about the coalition, about being nonpartisan.
Yes.
Why?
Well, we want to be nonpartisan because we think everybody should really understand what Medicaid is in the way I didn't until recently. And also then think for our public leaders what they can do to help. Again, the solutions have to belong to all of us, not to one political party, to another party. And so we want to be very inclusive, share our understanding, and see what people think, and try to show them what we think we know.
Yeah, it's so important because there's such a temptation when coalitions start. We've got to be active, action-oriented. We have to become really have to take on a promotion of particular ideas or suggestions or change of public policy. So how do you avoid that temptation, John, to really become more active in directly influencing public policy and how it gets rolled out in terms of specific activities? How do you protect the hospitals, nursing homes, etc.?
Yeah, we've been trying to be very clear to ourselves. We do have a steering committee now. And one of our steering committee members is a very hard right person who keeps us in line. When we start to veer off in any way, or anyone does, we try to be very respectful of people's current leanings, and that's, I think it's very possible to be very hard right and still be very understanding and supportive of giving care to people who have no other choice. It goes by the name of Medicaid.
Given the importance of Hudson Headwaters, Medicaid, the hospitals, nursing homes, if some of the cuts go through as it's been, how would you call it, touted and or fought for or against, what have you, how does this ripple through this healthcare system? And I use the word system advisedly, because healthcare in the United States is clearly not a system.
Yeah.
Right. So what do you think the ripple effect is if you take just one cut, like for instance the hospital, and then you kind of start going through our primary care?
Yeah, well, the cuts are everywhere, and if somebody loses coverage, it jeopardizes placement in a nursing home, coverage and access to the hospital, or having a medical practitioner to care for. We can go through it. For hospitals, there are 15 hospitals in the North Country. And of those 15, 9 are very small. Small, we call it critical access, 25 beds or less. And these are the ones that require special funding and special consideration and may well not make it through the next several years. I've heard from a senior government official that they are looking at the possibility of 50 small hospitals, mostly rural, failing, going bankrupt in the next few years. So that's a serious impact. In addition, even the hospitals that are larger and are doing better, there are challenges. For one, caring for somebody presenting at the emergency room ramp means they have to take care of them. And as Medicaid and insurance coverage goes away, there'll be many more people who have no ability to pay and no insurance to cover their costs. And that will continue to be true if they turn out to be admitted to the hospital. So hospitals are certainly a significant risk. Providers, medical practices, be they private practitioners, be they hospital clinics, or something some people may have heard of, community health centers, that's a problem. For one, community health centers are required to see everybody insured or not insured and all the rest, and so that can be a challenge if some of these people turn out to be uninsured. But there's a bigger problem, and that is, we've got people here who know this firsthand, Dr. Way and Dr. Bush, that if you've been here for any period of time, at least more than a couple of weeks, if somebody comes to the door of the office, there's no way to say, no, can't see you anymore, sorry, go someplace else, when there's no place else to go to for miles and miles and miles and miles. Unless they think, well, I will do this because it's a moral responsibility. The only thing is I won't be able to send my kids to college. That doesn't happen very often. So we really do depend on the coverage we have to make sure that programs exist. Having said that, I want to say that Tucker Slingerland, my successor at Hudson Headwaters, feels very confident because of the level of community support that we're not going to see a closure of any of the health centers. Shrinking of services, hours, and all the rest is a dreadful possibility. And then there are the nursing homes. something like 72% of the nursing home residents in this rural area of ours are Medicaid. 62% of their revenue is Medicaid. The difference is made up by people having Medicare and being discharged from the hospital or just coming down with something bad, and up to 3 months of Medicare coverage in the nursing home for rehabilitation. After 3 months, they no longer qualify, and they either have Medicaid or they have other kinds of resources in their pocket, or they just have to leave their coverage. And so the nursing homes, as much or more than any other kinds of facilities, are at severe risk of closure. And if that happens, where do the people go? They go back to homes, or their families can't work, they go into the hospital, so there's no room left for people who are newly sick. You can imagine the stress. And this is especially true in our area because we have the most stretched out delivery system anywhere in the state. That we need to avoid the prospect of medical deserts where there's simply no place to go, no elsewhere to go.
Follow along on that. Why is the North Country so vulnerable? You say it's stressed out.
Stressed out.
Certainly stretched out. How about stressed out?
That too.
But why is the North Country so vulnerable?
Well, we are not the richest part of New York State. And the level of income here means most people have to work hard just to make it. And therefore, the prospect of having to travel a long distance to get care because their local services closed is really pretty horrible. And again, if you're in an urban environment, at least we think, you don't have to travel too far in the bus or the subway to get someplace where there's health care. Here, we can't do that. We've got all those mountains in between.
So an example would be the Elderwood is the only nursing home between here and Saranac and Lake Placid.
Yes.
In the North Country. When you begin to think about that in terms of its, not only being stretched,
Right.
but also stressed in terms of being responsive to the community.
Yes, absolutely. Some people may know that Elderwood was looking at closing already just a few years ago because they weren't finding out whether they got a certain state grant or not. They didn't feel they could make it. Well, lots of things came into play, including a community responsive horror. And so they're still here. But Elderwood in North Creek, just like Elderwood elsewhere, is on this cusp of financial instability. They're caring people, I know them up and down, but you can only do so much if you don't have resources.
In the coalition paper, as well as some of the other material you've used, you began to start talking about the specific impact if the federal cuts come through, potential loss of the billions of dollars, or North Country, number of individuals who would lose coverage. Want to tell us a little bit about that specific impact?
Yeah. Again, nobody can know for sure what's going to happen next. But the national budget shows a $1 trillion cut over a 10-year period. And that cut is directed toward Medicaid and one other related program that is not Medicaid, that is SNAP, Supplemental Insurance Nutritional Assistance Program. We've heard of that, right? So in the North Country, we have 46,700 people who are expected to lose their Medicaid coverage. This is 27% of 28% of the people. 170,000 people now have Medicaid. 46,700 are expected to lose it, most of them over the next 2 years. And as an additional feature of this, it's not that alarming to many of these people who have Medicaid because they don't know they have Medicaid. They think, I'm on Fidelis. No, I have a Blue Cross plan. It's not Medicaid. Yes, it is, but it goes by different names. And that's part of the complexity and the confusion that leads to what could look like indifference, but is simply not being aware of the complexity of insurance and how they all interrelate. And for one, I can't claim to know it all, but know just enough to feel something between concern and alarm.
It's a major point to understand. Almost all of Medicaid flows through third-party payers, the big insurance companies. They're the emblems, the Blues, the United, MVPH, Fidelis, etc. The state did that a number of years ago in order to move through $103 billion is the state Medicaid program, just to kind of put it in context. All of that money flows through managed care. And when these particular companies, like recently MVPHP, are making some major changes, that ripples right through the whole healthcare system, whether it's private insurance, public insurance, the Medicare, special plans, whatever. So your point is really well taken. You know, I've been coming up, Sally and I have been coming out here. We started to ski at Gore in 1968, and then bought our first home in 1971. Everybody kept talking about the North Country, or the Adirondack Park. In your coalition, you call it the North Country Coalition. Could you put some definition around what the North Country is?
As I mentioned, it's 10 counties, bigger than the Adirondack Park, but the biggest thing inside the North Country is the Adirondack Park. It is roughly the size of the state of Connecticut. Unlike national parks where there's nothing there are some roads, country roads, there are some hamlets and villages, and so there are people. As I said, we have 608,000 people over the whole North Country we live here, but one estimate is 12.5 million people are coming here as visitors every year. And so that means they're part of our economy. And if we lose healthcare in areas, that can have an impact on those tourists. And some of those tourists have settled in and are really second homeowners. Within this whole North Country area, catch this, more than half the towns have more than half of their houses owned by people living outside North Country, but are here for the season. Whether that can erode and even collapse if there's not assurance of health care is a consideration. And it's just one or more of those factors in addition to the individual harm or if there's mentioned harm to the whole economy. Estimates are that this damage will amount to something like $1.2 billion for the North Country over time, over this period. And that's a lot of money here. In addition, it's going to have affect not only the Medicaid people, but all of us. For one, every expectation is, every certainty is that health insurance premiums are going to go skyrocket. Best estimate is, over the next few years, about double what they are now. So many people in the next year or two are going to have $1,000 more per month for their coverage. When we have a population who work for and do business, small businesses, not General Motors, not the big businesses, they're simply not going to be able to afford providing health care as a benefit in the way they've been able to do up to now. So not only are the Medicaid people going to lose their coverage, but people working there no longer have insurance offered or have it not offered at the extent of the cost, $1,000 a month cheaper to pay themselves. Many, many other people are going to say, I just can't afford this. We need food and education for our kids. And this can lead to not just a healthcare crisis, but an economic collapse. Something for all of us to be concerned about, not only as socially, but also, too many times, personally.
It's a lot to absorb, John. It's really. I have a question
Took
for
me a
Bibi.
while.
I have a question for Bibi then.
He's trying to sleep through it.
No kidding.
Clear, it's
Ah.
gonna work.
So what we're going to do is turn to the audience. We have handheld mics. If you raise your hand, I can't see your hands, but we have mics. I'm not sure how they are being distributed. Comes kid, she does everything.
No pressure, but if I can't answer anything, Dr. Way is here. He's only been in North Creek for how long at the North Creek Health Center?
So it's open to the audience here.
Dr. Bush has been my partner in Chestertown for all those years too.
Questions for folks? From you, to John?
Have I shocked everybody into silence?
Yes. Here's a question over here.
Chuck.
Chuck. Stage left. You have to swallow it.
Now we hear you.
Not close enough.
Why is it
There we
expected
go.
that all the healthcare premiums are going to go up?
In part because if healthcare facilities of any kind are losing a significant number of their revenue from patients who no longer have insurance, they're going to need and insist upon higher reimbursement on the commercial side. So instead of this being a tax now that we pay in that way, it'll be a tax we pay through our insurance premiums.
So let me contribute a little bit to that.
Please.
You know, having run teaching hospitals in the city of New York, the cost of care continues to exceed the rate of inflation. It has been going up on an average of 8 to 12% a year for the last 20-some years. Now, healthcare consumes about 18.5% of the national economy. And so what's happening, running hospitals, nursing homes, whatever, the technology increases. The labor cost, which is about 65, 70-some% of all cost of care, that just continues to grow to the point where government, if they're not improving Medicaid and their ability to pay, what happens? Who absorbs that loss of revenue? This is how it starts to ripple through. And what I'm hearing now is private insurance. They're talking about renewals for 15, 20, 25% for this year alone, let alone potential losses that providers are going to have.
Question. I don't know if this gets too partisan, but I know there is a bill in the New York State legislature for single payer. And is there any chance that that would ever go through? Because it does seem like what happens at the state level, it can be very important.
There is certainly reason for this kind of concern and these kind of bills being proposed. The United States, among all the world nations, has the most expensive healthcare system of any, double many European countries. As a consequence, not as a consequence, a side effect, I don't know what this is, but the quality of care and the mortality rates for the U.S. among the 32 most developed nations, we rank number 32. So we are spending a whole lot of money, and I think the current bill, H.R. 1, is based on we're spending too much money. We have to find ways to reduce it. But if we're only cutting one slice and not addressing total reform, we can't make it. The difficulty with total reform, you can imagine, is there are a lot of interests and a lot of profit making going on by insurance companies, by drug companies, in some cases by hospitals. Unfortunately, in New York, we have only not-for-profit hospitals, but these are all motivations that collide with one another and lead to bigger costs. So it would be great if this were the start of real reform, so we could do better with less. but slashing one program is only going to create more of a crisis, I think.
Other questions?
So what would you like to see?
Lots of opportunities here. For one, we would love it if people would join the coalition, so we can keep updated with what we're seeing and communicate that out through emails and papers and reports and the like. And for the people in this room, we can offer half the price. Slice it down to zero. So, a best way to reach our website, try to remember this, if you don't have a pencil, is North Country Medicaid. NorthCountryMedicaid.org, if you want to get fancy, will bring you to our website. We used to pay for that service. We've now brought it under our own auspices so we can do it, thanks to a lot of volunteers and a webmaster. And for a few months, we simply didn't have it updated, but it's being updated now, including the white paper that Arthur has mentioned, where we try to describe in a big overview fashion what's happening, why is it happening, what can we do next, and again, the communications and the support, including encouraging people when they meet their public officials, local supervisor, town board members, happen to run across damn stuff. Mention how this is important. We're really worried about healthcare generally, and that means paying close attention to this. For all that, what we know is that the new federal legislation, HR 1, is going to be costing the state budget $10 billion per year. And there's an additional $3 billion that goes directly from the federal government to providers, hospitals, nursing homes, practices. So the damage to the healthcare people, providers, is $13 billion per year. This state already is making indications of having a deficit, although there is some reserve money. And so we're being very careful not to say you need to send more money as a coalition. Individuals, we can do whatever feels right. But as a coalition, we think that could undermine the message we're trying to convey. We need to do everything we can. And if we don't have millions or billions of dollars, what else can we do? Well, we can make sure that if an emergency department closes, there can be an urgent care center established, like the Warrensburg Health Center. But not taking the usual 2 years to have it there, and maybe not totally for free in order to have the kind of coverage day and night that we need. So that's one example. Another is we need better broadband, because we should be able to communicate with our specialists and even our primary care people and get care over the line. It really worked during COVID. Unfortunately, Medicaid is now slated to stop all reimbursements for remote care. But at least we can do what we can as a state to say, you're in Medicaid, as the state regulates Medicaid, and you need an appointment and can't get there physically, call. And that can work. It does work. Not all the time, but many times. So these are the kinds of considerations we are giving. Talking to a very senior person with the health department, I mentioned about broadband. Oh, no, I don't know. We don't know how to do that. It's the health department. We don't know about broadband. But the whole state has to come together. This is not a health department problem. It's a problem for all of us to solve together. And so for the people who are here, and your friends and your neighbors, who can just talk this through and talk this about, will be what we need to create sensitivity and sensibility and awareness of what the need is. We think that'll work. When we first started, we, as a coalition, a few members at a time would go to one town board meeting or another, and then county board meetings. and describe Medicaid. At the beginning, some of those meetings, I got to see firsthand some people scowling, town officials. By the time I heard what was at stake for that community, and what was needed by way of understanding, these towns were unanimously passing a resolution that we had provided to them. There was one kind of exception. In one of the counties in the North Country, I had a visit early on and described Medicaid, and I would like to see some summary of this. So I prepared a memo.
Yeah, right.
A couple days later, and he sent a letter to the president. At that first meeting, I also said, we're going to have a press conference. Would you be willing to come and speak at the press conference? Because you seem to be sensitive to all this. Oh, sure. When I called him a week before the press conference, well, we have to be careful. I don't think you should come, John, to our county meeting or to a town meeting. No, that wouldn't be good. And it's clear what happened. That letter to the president resulted in a call from the White House saying, any more trouble like this, and we're going to take away all the health care funding or any county funding that we can. We have to be careful. Less careful now that we're dealing with the state. But still, we have to be good citizens. We have to be judicious. We have to be not outlandish. This is not the only problem they have, but it may now be the biggest one and the most difficult to solve.
So, putting a little fine point on that, people may not understand this. Medicaid is 50% of funding comes from the federal government, 50.3 or whatever, doesn't really matter. The other 50% is made up between counties and the state. It's one of the few states in the country where they have county share. The county share has been capped for a number of years, but still the impact on the counties is really quite large. I think it's a little over $8 billion, with the majority of it coming from New York City. But nevertheless, what John is saying, all levels of our government are impacted if Medicaid gets cut.
This was a special feature of New York State. It was the first and most significant one to pass some of the expenses from the state to the counties, both of which matched the federal 50%. The state over time became, by reputation anyway, and by good judgment, the most clever of any state in the nation. For example, New York State has imposed a provider tax on managed care organizations and on healthcare organizations. A tax, even though they're not-for-profit and all the rest. And that tax goes to Albany and represents how much the state is paying. And what that leads to is a higher level of federal contribution because the state is paying so much. But what do you know? A few months after they pay that tax, they get it right back. So they're not penalized, they're simply loaning the money so we can have more federal support, all of which is now going to go away. So this is the complexity we're dealing with. And it's building upon, again, 6 decades, 60 years of adaptation and learning, and it's going to become unwound in a matter of months.
So the coalition's been very helpful. John, you just took us into the third level of analysis, and people kind of scratch their head. So managed care gets Medicaid, and then the state taxes that revenue, and then they take the proceeds from that revenue and match federal dollars?
They do that?
I don't know who put that together. They had to be out of their mind.
We've done it like no other state.
No, I know that.
So maybe that's in mind. Yeah.
But what it gets to is the coalition has really tried to open, like an onion, just continue to peel back because people don't understand the complexity. And once you understand the complexity, all of a sudden it gets so confusing. We want to keep the message simple. The coalition message is simple. Medicaid is too important for people's lives. Medicaid is too important for the economic viability. Medicaid is too important to ensure access to health care. Medicaid is one that we can actually say it affects everyone. Let's make it nonpartisan. So that as we do the analysis, at the same time, whether it's second, third, or fourth level analysis, you have to come back to it and say, poor folk in this country, in this state, individuals with multiple disabilities would not have insurance without Medicaid. Other questions? I'm sorry.
Well, now you know how imperfect the coalition is. Instead of asking questions, he's answering the questions. We should have reversed this. Arthur knows a lot.
Here's a question over here.
Yes.
This might add to the complexity. I'm hearing that the 340B program, and Congress threatening to tinker with that calculation for small rural healthcare systems like Hudson Headwaters. In some cases, it's actually a bigger component in your budget than the Medicaid subsidies. But I don't think I've ever heard you mention that in these talks. Are you concerned about that?
It is a reason for concern.
Just to make sure everybody heard, a 340B program, it's a funding program done by the state, by the federal government, and John knows it well because that's how Hudson Headwaters is able to grow.
Yeah. Basically, what transpired in the early 1990s was the federal government going to the pharmaceutical companies and saying, for any federal purchase that we are doing, like for medications for the Army members, you need to pay us the lowest price. So if you have a special discount somewhere in San Diego, that applies to the cost we pay as the federal government for members of the military, for people that goes forward. Sometime later, in 1999, this was expanded to include community health centers like Hudson Headwaters. So that we are allowed, Hudson Headwaters is allowed to purchase medications from the manufacturers at the lowest price they offer in the federal government. Hudson Headwaters is, as particular, was benefited largely from this in part because many community health centers serve mostly Medicaid, where a little different, and the uninsured. We here, I think everybody knows, serve everybody. And because people, when they buy their prescriptions and have insurance for it, the insurance pays the drugstore. But the drugstore, instead of buying from the manufacturer or from the middleman, buys their pharmaceuticals from Hudson Headwaters. They make the same profit as they always do, but the discount is available to us and we've used it Hudson Headwaters has used it for several reasons. One is to be able to give better discounts to people who don't have insurance. So instead of paying the pharmaceutical price, they get a steeper discount. And another is that became a source of capital funding for building new buildings, buying x-ray machines, all that it takes, that governmental grants for operations to help is not covered. So this has been a big help, but the pharmaceutical companies went back and have been shriveling this down significantly. It started before HR1, before the Trump administration, and it happened because it was being more used by hospitals than ever, and therefore the material says that invest a lot in the lobby. And not to brag, but Hudson Headwaters is one instance in which we were sort of a national pilot exception. When this program first started, a health center was able to use one pharmacy to provide those discounts. And we came in and already had a dozen health centers and a dozen pharmacies. And this made no sense. So we were allowed to pilot whether it would be okay. Would this be subject to, this will be subject to an audit. We've never had the 340B program before, but if it looks all right, we'll make it a national scope program. Looked okay, and here it is. So, in part because of the amount of community support we have and the endorsements that you all represent, we've been able to do that kind of thing that has made it possible to expand from one health center in Chestertown to 4, including Chestertown, Warrensburg, North Creek, and Indian Lake, to now 26.
So on this, John, just to kind of pick up a little bit on this, is 340B is a mystery to many, many individuals, including those in the healthcare system. If you look at the recent Pfizer and Lilly agreements with the president, essentially what that is intercepting the discount that John is talking about, that otherwise would flow to community health centers across the country. And so what we're seeing is the federal government specifically interfering or attempting to change the flow of public funds for certain drugs that are actually going to be discounted to the federal government, but the discount flows back to the federal government. And we can get into all that. But the 340B program is here and now. It's not like we're waiting around for 2 years. That is actually going to happen here. Who knows what's going to happen in reconciliation.
It's already been happening.
Yeah, it's going to happen. So, other questions?
So, plenty of doom and gloom. These days, I guess we expect that. But Dr. Rugge, I'm going to throw you a softball. It seems like every contact I've had with Hudson Headwaters, the services are provided quickly, efficiently. The smiles are genuine. Your people seem to enjoy their jobs. All of that is unexpected in attending regional healthcare services like this. It's like you're heading to the DMV. No, it's not like that. And so maybe I've just been lucky, but I don't think so. Tell me what's behind that.
What's behind it is our communities. The appreciation that we feel. Initially, it started because there were 3 physicians in Chestertown in 1974. 2 were married to one another, ready for retirement, and then coaching that over the years with longer and longer and longer winter vacations. Dr. Halliday was only 42 and fully expected to be there for the rest of his career, and there was no worry that same summer he left for Cape Cod. And the town was jostled. What are we going to do? They formed a search committee, and Howard Swan and the supervisor was able to place these really touching major stories in the New York Daily News. And so, a physician from Yonkers called and said, yeah, I might be interested. Chestertown, that could be good. I would want a free coffee pot. And the search committee said, what? He is going to earn more than any of us. Throw that one away. You can't do that. And so that didn't happen. What happened was they went to the hospital, Winslow Hospital, and the hospital responded to the CEO, Bill Finley, and said, well, we have 4 PAs in training now, and they're completing the training at the end of the summer. And they'll be looking for some place to go because there's nothing like that around here. And Dr. Hauser, who was there, said, yeah, but they need a supervising physician. But there was this guy who came through looking for work in the ER for a couple of months or a few months. Maybe he'd be interested. So I got a call. And so we ended up with this team of people going to the town of Chester. And what transpired was the town agreed to buy the home office of the Drs. Trenks, Felix and Susanna Trenk. And the town and the hospital did the charging and all the rest. It was a lot back then. It was $10 a visit, no matter what you had. And at the end of each year, the town was to receive from the hospital half of any profits. Well, there were no profits. And the town then decided to pay the mortgage after all. And it was very strict looking at the budget every quarter to make sure that there was not some money to be returned to that town for its share of the mortgage, and never was. So the hope was they could expand, the hospital could eliminate the deficit by having Warrensburg open and then North Creek open, because there'd be more patients. And that would spread out the losses and da-da-da. Well, on a per patient basis, it's did, the deficit went down. Overall, the deficit only went up. And then finally, the hospital decided they couldn't afford health centers anymore, and was looking at closing, starting with Chester. My approach was to go to Bill Orlock, who was our PA then, as the PA, and ask him if he would mind tending the health center with not quite so much help, actually no nurses, no front office, just him, doing it all. And he did, and that's how we kept the doors open. So what it takes is for a rural area like this, it takes something special, either a hospital really interested in referrals and making good money, or a community health center program that has special attention for people in need. But again, back to the original question, why so friendly? Well, it's because this community response was so appreciative. And Bill Orlock, what I just mentioned, about a year or so after we joined, this would be about 1977, came to me to say, we just got a big job offer, a lot more money than we could pay or we're paying. I said, we can't afford to pay any more, Bill, but we really need you. He said, well, I think I'm gonna have to leave. About a week later, I was able to go to Bill and say, you know, I think we're gonna have dinner together. We'll go to OG Fabrics. And we walked in, and there were 200-300 people there, all crowded in, saying, Bill, it's so good to see you. We're counting on you. Do you remember what you did for my mom? At the end of that, he couldn't leave. And that same level, that same kind of approach is returned with smiles and making every effort to be there in time. So blame yourselves. This is a community that's been very special and gets some rewarding from that.
So, John, do you know any of the statistics right now about Hudson Headwaters? How many clinics, how many people they serve every day, just to kind of put things in perspective?
Yeah, we're serving.
By the way, he constantly personalizes this, right? We.
Thanks. Sorry.
Tucker, are you in the audience?
They have 26 health centers. They have 490,000 visits this year, patient visits. And that translates into, I'm forgetting the number of patients, we can say, it's a big number. And it's basically for the region we serve, which is awesome. It's not, we don't include all the park. We include the eastern side of the North Country, which is the size of Connecticut. And in that area, we take care of half the patients. Initially, it was only the remote, needy areas, but now it's Plattsburgh, it's Glens Falls, and everything in between. So we are.
I think I heard the number. Was it about 100,000 individuals?
No, it's more than that. It's, I think the last number I heard was 325 or something.
So it's half the population of the North Country.
Yeah.
Any other questions?
Testing.
Keep it right close to your mouth.
Trying to be very musical.
Hear me? I
Yeah,
guess you
there you go.
John, so nice to be here. I've lived here in North Creek since '89 and had incredible service. I mean, every time you call Headwaters, they respond to you. But recently I had a problem with endocrinology. You can't find, doesn't seem to be involved in the system. You have to go miles, you have to go months to get an appointment. So I wondered if there's any reason for that we can't get an endocrinologist here.
Yeah, I think that by here you mean Glens Falls, or anywhere short of Albany, not here in North Creek, right? Yeah, just trying to make sure I understand the question.
Well, it's just that I had the worst time trying to find one, and I had to finally go to Wilton, and it took like 3 or 4 months to even get an appointment. And I tried to go through Headwaters, and they didn't seem to even know, where to go.
For some of the specialties, there is literally nowhere to go because there is a physician shortage generally, and there is a resistance to practicing in small cities or or rural towns. So this has been increasingly true over the years and the decades of specialties who were formerly everywhere, including Glens Falls. Now, going back to the academic medical centers, the closest one being Albany and the next closest being in Burlington, Vermont. So I'd like to think that Hudson Hill Waters is doing its best to expedite this, but there's a limit in terms of what kind of receptivity there is from those specialists.
Thank you, thank you.
Yeah.
Another question over here.
John, I want to force you to be political for a second. So, 2 political questions, and I know we're supposed to be nonpartisan. So, question number 1 is, as you know, our congressional representative is now running for governor. She's fully aware at all levels of this issue. Has she addressed any of them in her campaigning? Number 1. Number 2, can the Healthcare Coalition safely ask the question of her what the plan really is? I mean, the real plan, not the plan to plan for a plan, but the real plan, because she's going to be stepping into a mess.
Well, as a nonpartisan, non-political representative of this coalition, along with you and others, I can only say what happened. And that was, despite all the receptivity we had locally and regionally, when we approached Congress member Stefanik, we got simply no response. She didn't say no, she didn't say anything. Tried phone calls and letters and memos and voicemails and just didn't respond. I think because there was a very tight administration and knew what it wanted and was making sure that no one was contradicting it. All that, at least Stefanik has over time been a big supporter of the North Creek Health Center and all the other Hudson Hill Waters centers. Within 2 weeks of her taking office, way back when, she happened to pay a visit to the Warrensburg Health Center, take a tour, and then went on to establish the Community Health Center Caucus in the House of Representatives and became its first chair. So there was a history of support, but in the political environment has changed the way we think we have to be stepping aside from taking sides, but simply tell everybody, because things change and hopefully people who've been resistant will change too.
So let me pick up a little bit. One of the values of the coalition is changing the narrative, making sure the headline talks about Medicaid and the people it serves. What's happened with I would call it the presence of, whether it's Stefanik or Health, they've captured the headline, essentially saying these cuts are part of reducing fraud, waste, and abuse. They've captured that headline, essentially characterizing, whether it's Medicaid or any other healthcare program, the amount of fraud, waste, and abuse. There are some statistics that really dispute any of that. So part of the problem is what the coalition is doing in a very positive way is changing what that narrative is. Here's a question up here. And also, Candace, give us a highlight about the time, what we're doing.
3 o'clock.
Huh?
It's 3 o'clock.
We got one more time.
Is that Eastern time, daylight time? Okay, Western time, okay. So what we're gonna do is take a few more questions because we promised you that we wouldn't be up here that long. By the way, John and the coalition are very open to taking comments and questions. I've just seen some pretty significant comments and questions they're responsive to. And we'll talk about how to connect on that in a minute. Just take one more question up here.
Let me repeat one thing. NorthCountryMedicaid.org, North Country Medicaid, and you'll find everything we have there, but also the opportunity to ask questions. And we will get back to anybody who has a question. whatever the question is, we'll do our best.
And I'm going to give you John's private email.
Good, that's okay too.
Yes.
I'd like to ask a question. Talk to me more about the coalition. It seems that raising public awareness is a big part of the answer if we are going to reduce costs and have comprehensive reform. Is the coalition just in New York State? Is it larger than that? Or how do we make it larger?
Good questions, and gives me the opportunity to see something I totally forgot to mention. But first of all, we are concentrating on the North Country, and we're concentrating on Medicaid. We're not dealing with so many other issues which are very important too. We, over time, have learned that there are certainly a number of organizations all around the nation, and some of them with national scope, that have the same interests that we can learn from, but they also learn from us about the circumstances here. So we're not competing, we're simply trying to do what we can here. And what we have found was, to my surprise, big surprise, that other organizations who are providing services to social services of all kinds, help with food, help with and whatever, take a look and say, oh, these people know something about Medicaid. What can we do? Maybe they can be a voice for us too. So we had a lot of encouragement and a lot of support. Having said that, more to this point, our initial approach, as we've talked about for more than an hour, is how to get the message across how important Medicaid is and people understand in some depth what it means. We think now is the time when we also should be the catalyst, the inspiration to help providing support to beneficiaries. What's coming through these cuts is not only slashing reimbursement, but creating new documentation and reporting requirements. Mostly starting a year from now, every beneficiary of Medicaid is going to have to submit an application twice a year, not once. And instead of being done automatically, you just have to make sure your taxes are in, and then you use the tax form to know whether you qualify for now. Now it's going to be demonstrating, perhaps hour by hour, how many hours you worked this month, and last month, and the month before, and the month before, to show if you really still qualify. Because if you work less than 80 hours a month, unless you are disabled, or a caregiver for young children, or a full-time education, you need to work those hours or you lose coverage. Many people don't even know they're on Medicaid, and they're not going to bother with this. They don't think it applies to them at all. And when they do know, they may not be able to fill it out, because how do you get this kind of documentation? What's documentation mean anyway? And so we're looking for people who, as part of other organizations or eventually part of the coalition, can go to people in their community who may need support. Meeting together and saying, here's the form, here's what you need to fill out, how can I help you do it? This is what you need to provide, and here's how you have to provide it. So that's going to be new. So far, we've not figured out any super way to do that. We think that's coming very, very soon, as early as January, in terms of some of the new requirements.
So one of the things the state has done is called social care networks, which is linking the healthcare system with the social services just John talked about. Every Medicaid individual will have access to the social care network. This is in the North Country, it's Healthy Choices. And so this connectivity that you talked about is really important. We've taken up.
And as we learn more, it'll be on the website, it'll be going out by way of emails to people as well. So, we don't have nearly as much definition of how to be of help in that way as we can describe what Medicaid is and what the impact is. But we need to get there, and we can only do that with lots of help and a lot of community endeavors, supporters.
Thank you very much, John. Just one last hairball question. You may not know this. It's round out John's kind of career sector. What does wilderness canoeing have anything to do about being a doctor and a leader? Besides being lost in the middle of the Arctic and/or dealing with massive black flies and ending up with black fly fever. Could you tell me how that connects?
It didn't help about becoming a doctor, actually, but it sure helped about where to come to do any doctoring. The sequence was we took there were 4 people that took a wilderness trip to Labrador. At that point, very uninhabited, really truly uninhabited province area of Canada, and canoed whitewater, canoed the river, canoed the lakes, and along the way had the bright idea, we should write a book about this. So now all 4 of the 2 of us gave it a try. And when I was at Albany Med, after medical school, getting my real training, got a call from the publisher who said, we'd like to publish this. When could it be available? So I interrupted training to come and picked the only logical place to come, Sodom.
Anybody know where Sodom is, besides Gomorrah?
Well, Sodom, actually, because I thought this question might come up from Arthur, I looked up today at Sodom, New York, and they said, yeah, they didn't describe it as a village, certainly, and they didn't even describe it as a hamlet. They just said, Sodom is a neighborhood near the surrounding cities of Baker's Mills, Weavertown, and Darrowsville. But anyway, having done that and looking for a short plan to come for 6 months, and knew to come to Sodom because of Gore Mountain. When I was 14 years old, I was skiing with these adults who had a ski club, and I joined because one of them was the stepson of my art teacher in school, and there was a poster on Gore Mountain saying the 2nd annual Derby is coming in May, the Whitewater Derby, Hudson River. Yeah. So of course we had to make that, and then having made about every year since then, from 1959 to 74. This was the place to come. And what a reward. The community is so supportive, so here, and the only reason some people sometimes say, boy, you had such a vision. I had no vision. I was there because 3 doctors had left town, and then realized over the next several months that most all the doctors in the surrounding towns to the north were about to retire or leave practice in one way or the other, because they all arrived at the same time. They all arrived in 1945 or 1946, and they were fleeing Hitler because they were Jewish. And there was a pathologist in Glens Falls Hospital who had ties to the Jewish Refugee Service, and every now and then he'd get a call, Dr. Maslin, we have another one. Where should we send him? Well, he can go to Spoon Lake. He can go. Actually, Dr. Grumblot didn't come to North Creek because of that. He was a little earlier than that and had a more circular path, but of the same type, ready to retire in the same few years. And the prospect of a medical vacuum for this area, eventually stretching from Warrensburg to almost Plattsburgh, is what led to state's attention, and state support, because this would be a big area to be embarrassed about. It would have no physician because it's simply becoming impossible to practice a solo practitioner and make it. One needed so much more technology and so much more support and help, and physicians just weren't doing much by way of solo practice anymore. So here we are together.
So canoeing then?
Brought me here.
Yeah, okay.
Didn't take me to medical school, but it brought me here. So when the time came, this is the only place to arrive. It was a great choice.
It's great. Thank all of you for your attendance and your questions. Thanks Tannery pond for its Tannery talks, and especially want to thank Dee Dee.
I want to point out how very interesting all this BB.
And thank John again. It's
Thank you so much. I just had one quick thing I forgot to mention at the beginning, but Art was saying at the very beginning that this is a part of our series. So this was the first year we did Tannery Talks and workshops. We had 4 workshops and 4 Tannery Talks, one a month from April to November. And we're planning to do the same thing next year. So if you have any interest in a particular workshop or a talk, just email me, director@tannerytownCenter.org. And also, I just wanted to note that these Tannery Talks this year were sponsored by 2 important grants. One is the re-grant program through the Warren County Occupancy Tax provided to us by the town of Johnsburg. So we're very grateful for their support. And we also received a Generous Act grant from the Adirondack Foundation, Community Foundation, new name. So we are very grateful for the support of the grants. And then also, lastly, we're also grateful when you put $10 or $20 or something in our donation jar, because that's how we bring all these great programs to you. So every little bit that you've done for us is so important to us. And then one more thing, we couldn't do this without all of our great volunteers. So there's Donna, there's Sally, there's Dawn, there's Arthur, and there's others. I don't want to leave anyone out, but thank you to all of our volunteers who make cookies for you guys so you can have cookies on your way out, or who just are here to volunteer. So thank you to everybody.
old. In order to project oldness, which is put out, he goes back to his bunk in the chest, and he's gasping for breath. So they bring him down to the infirmary, and we were at the Schultz's, he's older than we were at the Schultz's. And he starts to hyperventilate. He's got frightened and scared now. We come and we decide we don't know what to do. So we're going to take him to the Chestertown office. He's supposed to visit the Chestertown office. On the way, he passes out. I'm thinking this boy is dead. Because all this trouble that we're going through, we're going to close tomorrow. And he comes to, and we bring him inside into the Chestertown office. He comes back in 2 minutes. I'm so sorry, Mr. Meltzer, put you through all this trouble. I'm fine, don't worry. He says, I said, what did I do to you? He said, they hit me as hard as they could and said, stop it.
That's a great story.
I'll see you later. Yeah, hurry up.
And after that, there's sort of a financing.
Okay.
Good, that's good.